So, many observational studies have shown a relationship between diabetes and an increased risk of dementia. This is a meta-analysis which looked at studies stratified by Western and Eastern countries. And the individual studies show, by and large, an increased risk across the two settings. Overall, a 1.5-fold excess risk of Alzheimer's observation in relationship to diabetes. And some postulated underlying mechanisms. And one of the things that Elizabeth Barrett-Connor, who many of you know in this audience, said to me was, if you cannot find a plausible explanation for an observation, you shouldn't be an epidemiologist. So here's a wealth of plausible explanations. Diabetes increases the risk of cerebral vascular disease largely because of attendant increases in risk factors like blood pressure. That in turn might increase the risk of dementia, perhaps by hyperperfusion of the brain. A second explanation, which is largely just focused on people with diabetes, is that the episodic hypoglycemia that people experience as a consequence of rather tight control may be the causal factor. And a third, not necessarily the most exhaustive list you'll see here, is that insulin resistance in the brain alters signaling and increases the risk of both amyloid plaques and phosphorylation in turn. So we also looked at the association between glycemia now across the spectrum and structural measures in the brain. So on the right, you've got white matter hyperintensity volume. That's a measure of structural damage to the brain, largely as a cardiovascular consequence. And we compared, we used a reference group of 35 to 42 millimoles per mole. In old money, that's an average of about 5.6% HbA1c. And we compared people with lower HbA1cs, pre-diabetes, undiagnosed type 2 diabetes, and known type 2 diabetes in the UK Biobank subgroup who came for imaging. And there's an indication that perhaps those with rather low HbA1cs had less white matter or hyperintensity burden, but with increasing glycemia, increasing volumes of white matter or hyperintensities. And even when we adjust for cardiovascular risk factors, you do see quite a marked attenuation, but perhaps some excess risk. Turning to the left, hippocampal volume, which you're seeing much more neurodegenerative, although that too has a vascular component. Again, a similar picture of those who have low normal HbA1cs having slightly larger hippocampal volumes, but greater atrophy with increasing glycemia. And that more persists with cardiovascular risk factor adjustment, as we might expect. And now looking at incident measures of dementia, the top panel is vascular dementia. And model 1 is just the sort of base model, age, sex, index of multiple deprivation, ethnicity, and education. What we see here is with increasing glycemia, increasing risk of vascular dementia. Model 2 adjusts for cardiovascular risk factors. You see some quite marked attenuation of that risk, but it persists. Less of a gradient, perhaps, with Alzheimer's dementia, but still an excess risk in people with known diabetes, and little in the way of attenuation when you adjust for other cardiovascular risk factors. And all cause dementia, a slightly mixed picture there, but certainly an excess risk in people with known diabetes. So observationally, we're seeing an association across the glycemic spectrum of both measures of structure and function. These are two studies that looked at post-mortem brains and looked at direct neuropathology, neurofibrillary tangles and neurotic plaques, and compared people with and without diabetes to understand the risk of these two structural outcomes. And the bottom line here is this: these two studies showed no real association between known diabetes and these measures of dementia. or risk factors for dementia, whether you, even when you adjust for other risk factors, cardiovascular risk factors as well. These are now live people, so these are data from PET MRI imaging looking at amyloid. 2 studies associating HbA1c with amyloid burden and showing perhaps a hint of an excess risk at wide confidence intervals in the first study, and interestingly, a greater risk in younger ages, associating that with PET MRI age 69. But again, wide confidence intervals and no really clear association there. And trials of glucose lowering, they haven't been that great. They've tried out intranasal insulin, the glitazones, particularly pioglitazone, metformin, and liraglutide. Very few trials, very small. 18 had fewer than 800 participants, short, and a mixed bag of outcomes: cognitive function, PET MRI studies, biomarkers, and so on. And for each drug, unsurprisingly, there's conflicting results and no really clear evidence that these drugs impact brain health. So we turn to Mendelian randomization as a way of understanding whether this association is causal or not. So on the left here, we've got measures of glycemic status, type 2 diabetes, HbA1c, glucose and insulin. So we have instruments for all of those and relate them again in UK Biobank to cognitive function, structural measures on brain imaging and Alzheimer's dementia, incident Alzheimer's dementia. And to cut a long story short, there is really no association between any of these instruments and any measure of cognitive function, structural damage, or dementia. So this replicates in part a previous study done in IGAP. This is a case control study of people with and without Alzheimer's. And here the instrumented type 2 diabetes, glucose, and insulin showing really not much of an effect on Alzheimer's disease. They also looked at measures, instruments of cognitive reserve, years of education, whether you go to college or university or not, and intelligence, and show a marked protective effect of these genetic instruments on Alzheimer's disease. So putting that together, we wondered whether the association that we're seeing between measures of glycemia and cognition are actually as a consequence of cognitive reserve acting both on the brain and diabetes. So these are data from the 1946 both cohort. Associating observation first, type 2 diabetes, insulin resistance, and HbA1c at age 60-64, with an instrument that assesses multiple domains of cognition at age 69. And observation in each of these 3 are strongly associated with adverse cognition at the age of 69. So the question was, is this association, path 3, diabetes, cognitive state, really a consequence of these 2 paths, the path between cognitive reserve and cognitive state in later life, and the impact of these early life influences on type 2 diabetes? So we used insulin resistance. We could have used diabetes, we could have used glycemia, but we used insulin resistance here in this picture, showing a negative association with cognitive state. In other words, if you're insulin resistant, you have poorer cognitive function in later life. And then we add these other factors, which I'm going to do here. And what this shows is that there are strong associations, as you would expect, between each of childhood socioeconomic position, childhood cognition, educational attainment, and cognitive state in later life. And these are very strong associations. But also that these associate with midlife insulin resistance. So once you take account of these, the residual effect is negated. In other words, there seems to be no direct association between insulin resistance, age 60-64, and cognitive function in later life. So what I conclude from this is that both Mendelian randomization and clinical trials, although they've been pretty poor quality, don't support a direct role for diabetes. Or indeed the extension to other hyperglycemic traits in older age, cognitive function, and dementia. and that the observed association is really because of the upstream determinants of cognitive reserve. And that trials, therefore, will show very little benefit, and we should be bothering about those, and really should just be investing in early life determinants of cognitive reserve. That's it. So I'll take questions. You're so convinced. George?
Do you think in terms of the observational data, there's a moderately strong sort of reverse causation pathway in the sort of type 2 diabetes risk and Alzheimer's disease, and that the genetic score for Alzheimer's disease starts predicting lower BMI to a not trivial extent by age 50, 55, and it's one of the quite not findings, which obviously would reduce your, then that would in turn reduce your risk of type 2 diabetes, being the major risk factor for type 2 diabetes.
So we've done some bidirectional MR, and that doesn't bear out particularly well. But having said that, the instruments we've been using, I don't think are that great. So maybe that's six. But I fully agree that you do see early signs. The Whitehall study shows early signs of cognitive decline right back to your 40s and 50s.